Hello everyone, greetings to all participants of this annual symposium in Russia. I'm Siniša Poznich, physiotherapist and PNF instructor from Croatia, from Zagreb. I would like to talk about physiotherapy treatment with PNF concept of the lumbosacral chronic radiculopathy of the S1 nerve root. This will be the topic. It's about, so I will present the case, and it's about 57 years old female that was hospitalized at the neurological clinic 16 November last year because of reduced sensitivity of the right leg in the area of S1 nerve root, and she was discharged 10 days later. By profession, she's a clerk in the bank. She sits 8 hours per day, and she has a hobby of hiking. And why I emphasize that, because we combine that with the motivations for physiotherapy. At MRI, L5 S1 disc protrusion can be found. On EMNG, chronic moderate lesion of S1 nerve root on the right side also can be registered. And she came to my physiotherapy clinic as an outpatient in June 2022, and we have been she has received 5 treatments until now. In assessment, her short-term goal, of course, she's to walk with normal sensation in the right leg without this sensibility. On the participation level, she's fully independent, but she has difficulties with the right leg sensation when walking the dog in the park. And from that participation activity level is that she's again fully independent, but she would like to improve the gait without feeling numbness in the right leg. That's her walk. This is she, and that's her gait. And from a function level, she has no pain, not mildly in the lumbar spine, but no significant pain, and neither in the right leg. But she has hyperreflexia of Achilles tendon. She has positive dermatal finding of S1 nerve root, so desensibility in this area of the 4th and 5th toe, lateral side of the foot, and the lateral posterior side of the lower leg. She has moderate, I would say mild, weakness of gastrocnemius muscle on the right side compared to the left side. She has, when examining nerve root mobility with straight leg raise, she's positive on structural differentiation, which is the foot. And in the lumbar spine mobility, she's hypermobile on L4, L5, and L5 S1 segment, tested with the joint plate test in sideline position, and the same for the thoracic spinal mobility. She's hypomobile in the middle and upper thoracic spine, tested by a joint plate in sideline position. On the muscle length test, she is tight in iliopsoas muscle, rectus femoris, tensor fasciolata, and tensor. So that's a function level assessment. And on those pictures you can see testing of the reflex of Achilles tendon, sensibility testing, strength testing for neotomes, and then straight leg raise testing as a nerve mobility test. Here on the right side, you can see joint plate testing of the lumbar spine in sideline position, and then the same joint plate testing as a mobility test of segments of the thoracic spine. Here I tested the muscle length test of quadriceps, rectus femoris, iliopsoas, hamstrings, and then tensor fasciitis. In the treatment plan, I will start with S1 nerve decompression, then lumbar spine motor control with an emphasis on stabilization, but I will introduce mobility, stability, mobility on top of stability, and skill as a gate. We'll treat nerve root mobility with a slider of nervus sciaticus, and then thoracic spine mobilization and extension, and muscle relaxation of iliopsoas, rectus femoris, hamstrings, and tensor fasciitis. So S1 nerve root decompression. So if we look her right side, where the nerve root is compressed, then I open this side with posterior depression with the dominant component of lateral flexion the opposite side. And then I put a roller underneath the lumbar spine, traditionally open this right side. Similar pattern with the anterior depression to open the right side with lateral flexion the opposite side. And then in a side sitting position to open the right side through the arm pattern, and then with a combination of scapular and pelvis patterns to open again the right side in sitting position on the elbow, and then sitting on heels, opening, and then squatting and opening the lumbar spine, intervertebral canal, of course. When we talk about lumbar spine motor control, I start with lumbar spine mobility or pelvic mobility exercise with an emphasis on posterior tilt, and then in this position, relative posterior tilt to come into the neutral position. And then I'd say to her to bring up the belly to activate lumbar spine stabilizers, primarily quadratus lumborum, and also posterior deep stabilizers. And then when she catch this position, the good position, then I start off with the mobility of the leg on top of stability of the lumbar spine, with flexion, adduction, external rotation, with knee flexion exercise. And then the opposite pattern, the extension, adduction, internal rotation with knee flexion. And then this is a little bit of adaptation to activate glutes together with lumbar spine stability. Doing the same in the different position, which means repetition without repetition that promotes motor learning and motor control. in quadruped position, so extension, abduction, internal rotation with knee flexion. So stable in the lumbar spine, mobile in the leg, in the hip, and then extending from a quadruped into a kneeling position and coming back. So having the lumbar spine stable and activating glutes, and then standing position as a progression, of course, bringing and coming to the gate, approaching gate. That means standing relative posterior tilt, and then afterwards stepping forward and stepping backwards as a mobility on top of this stability. So doing the same in another position. And as a last progression of motor control, that means the skill, changing the base of support, and in this case is the locomotion or the gait. And she's stable, she tries to be in the same position while walking and moving legs, of course. Concerning other goals in the same topic, I will show the S1 or lumbar spine nerve root mobility exercise with flexing first the head and moving nerve roots cranially, and then relaxing, and in the other part extending, dorsiflexing the foot, extending the knee in a flex position of the hip, and then repeating that first part, relaxing, and then repeating that the second part. For the purpose of mobility of the nerve root and sliding in cranial position and caudal. Then thoracic spine mobilization in extension. I put some foam roll underneath the thoracic spine, or also you can put the wedge, controlling the lumbar spine in neutral position, and then using lifting to the left or to the right or to facilitate mobility in thoracic spine, and the same in sitting position. We should took a lot of concentration to keep the lumbar spine stable while doing this thoracic spine mobility. And then some exercise to relax muscles that starts from the pelvis and can influence the position of the lumbar spine. That means iliopsoas first, and then rectus femoris, hamstrings, and then tendon fasciae. For this purpose, I can use static stretching or all the leg stretching, which is a typical way of stretching in PNF concept. So that would be it from assessment and treatment of the lumbosacral radiculopathy patient. Thank you very much for your attention, and if you will have questions, I will be glad to answer it during the discussion time. Greetings from Croatia.